Welcome to this evening's CUA WebEx. Welcome Dr. Welk and Dr. Carlson, and I'd like to hand it off to Dr. Welk to start off this evening's presentation. Dr. Welk.
Great, thank you very much. Well, thank you everyone who's tuned in to discuss transvaginal mesh and the management of stress incontinence, addressing the concern. Kevin and I put this presentation together in response to the CUA and members like yourself who wanted more information and wanted a forum to discuss some of the concerns around the use of it for stress incontinence. So disclosures are shown on the screen there. This is accredited for an hour of credits. Learning objectives. So there's a few things we wanted to be able to cover, and we wanted to try to make sure we left lots of time at discussion for discussion at the end. As mentioned at the beginning, if you want to type questions as they come up, please type them. They'll show up in the transcript, and at the end, Kevin and I will go through and pick out some questions to discuss between the two of us. Objectives: review the background of midurethral slings briefly, summarize the CUA mesh statement, learn how to educate and consent patients for mesh implantation, and discuss and answer questions about the current status of midurethral slings. So our outline basically follows those objectives. I'll start with the first 2 points, and then we'll get on to Dr. Carlson's part and then some discussion at the end. So what do we know? Well, we know that 1 in 7 women will undergo stress incontinence surgery sometime during their lifetime. So this is not an issue that's going to go away. This is something that's going to touch all of us, both in our personal lives and in our professional lives. We're going to see patients who want to have this kind of surgery done. Starting in the early 2000s, 90% of stress incontinence surgery procedures were mesh-based midurethral slings. This really was a procedure that swept all the other procedures under the rug in terms of frequency of its use, and really has dominated the treatment of stress incontinence in both North America and throughout the world. The advantages, as I'm sure many of you are well aware of, short operative time, quick recovery for most patients, generally speaking, very good results for the vast majority of women, and importantly, it's applicable to almost all types of patients. Obese patients, patients with low leak point pressures on urodynamics, elderly patients, people with mixed incontinence but stress predominance, people with more severe incontinence, and those having prolapse surgery at the same time. So at first, it's interesting to look back at some of the original review articles. This one was published in 2001. The TVT procedures being remarkably successful with very low complications rates and a very high patient satisfaction. And I think this is something that persisted in all urologists' minds over the course of almost a decade. When we look at the results here, 95% of people were cured or better after the surgery, and there were virtually no complications reported in the first few series. And this really, I think, set almost unrealistic expectations in the medical community as to how good this surgery was and how risk-free it was for patients. However, as everyone's aware, in the last 10 years, things have changed. Transvaginal mesh has been the subject of regulatory warnings regarding complications. It started to be reported in the literature, and surgeons and patients started to report on the specialty of meshology, or the removal of mesh and the management of complications. Things like chronic pain, urethral vaginal fistulas, voiding dysfunction, mesh erosions, all of these began to be reported in the literature, and this led to the initial FDA and Health Canada warnings. These complications obviously have captured the media and the legal spotlight. Calls for public inquiries in the United Kingdom went ahead. Australia and New Zealand have regulated transvaginal for stress incontinence to a second-tier procedure, and it really has captured media attention in terms of stories from patients who have had complications and really failed to find an answer in the medical community as to how to deal with these complications. This is an example. If we look at the mesh-related lawsuits in 2011, just after the regulatory warnings, there were a few hundred lawsuits filed amongst the different countries in the United States. When we look at 2014, just a few years later, it had gone up by 8,000%. And obviously, a large part of this is the medical legal incentives in the US and a lot of aggressive advertising by some of the medical legal firms there. But still, this just shows the magnitude of bias that we're fighting against sometimes when we introduce the idea of a mid-urethral sling to a patient. So in 2015, the CUA approached a group of us to come up with a position statement on the use of transvaginal mesh. Some other societies had done this, and several urologists had contacted the CUA saying they really wanted a position statement that they could sort of use to guide their practice. This statement came out of that request. So it was first published, I think, in 2016, and then formally published in the CUAJ in 2017. Statement itself covers both mid-urethral slings and transvaginal mesh for prolapse, but for today, we'll focus on the mid section. So summary, what did the mesh statement say? Basically, it reiterates the fact that the literature strongly supports the mid-urethral sling. They're as effective or sometimes more effective than traditional stress incontinence operations. Important point is there are rare but serious complications that have been reported. Of rare is a bit debatable, but the vast majority of women do not have these complications, but some do. And the important thing to note here is that these may not be fully correctable even with additional surgery. In the vast majority of cases, when a woman does get a complication, they can be addressed with further surgery. But again, rare cases, these can't be fixed. And that's something that's important to consider doing consent for these surgeries. Keep in mind that serious complications can occur with traditional non-mesh based stress incontinence procedures, things like wound infection, dehiscence, life-threatening bleeding, bowel injury, ureteric injury have all been reported with traditional stress operations, and this is potentially serious and life-altering as those associated with mesh complications. The CUA is not alone. So in this statement, it aligns quite well with what's been said by other societies, and it is consistent with gynecology position statements, the AUA, Society of Urodynamics and Female Pelvic Medicine, National Continence Society. They all reiterate these facts and support the mid-urethral sling for the treatment of stress incontinence. So really, the medical community has been fairly united in supporting mid-urethral slings. What are some of the recommendations that came out of the CUA position statement for transvaginal mesh? Well, the first four are the original recommendations in the initial published version of the CUA in the CUAJ, and mirror fairly closely the recommendations for that were published or supported by Health Canada in 2014 and 2010. So firstly, when transvaginal stress incontinence surgery procedures are offered to a patient, they must be informed of procedure-specific complications and mesh-specific complications. So procedure-specific complications are fairly straightforward. Something like voiding dysfunction, that's a complication of any stress incontinence surgery you do, whereas certain things that are mesh-specific, that would be specific to mid-urethral sling, include things like mesh erosion, mesh exposure in the vagina, or chronic pain related to the mesh. The 2014 Health Canada advisory around transvaginal mesh should be disclosed to patients, and the exact way you disclose this is a variable number of ways you can do this. One, you could give them the statement. You could discuss it verbally, which I think is probably the preferred way that most of us approach it. 3, surgeons performing these procedures should be adequately trained in stress incontinence surgery and specifically trained in the sling technique they use. It's not enough to say you don't know how to treat stress incontinence, but you're technically adept at putting in a mid-urethral sling. There's decision making in the clinic before offering someone a mid-urethral sling that relies on the basic principles of stress incontinence and the evaluation and treatment of these women with stress incontinence. You need to be adept at the basic evaluation and treatment of stress incontinence, as well as the surgical technique for the specific mid-urethral sling product that you use. Point 4 is surgeons should be capable of recognizing, diagnosing, and treating potential mesh-related complications associated with their procedure. And that's not to say necessarily that you have to be able to treat every single complication that's going to come about, but common things such as voiding dysfunction or vaginal exposure. If you're going to be offering mid-urethral slings, you should be able to evaluate a patient for these potential complications, offer them basic surgery or referral for management of these. Point 5 was added in the update to the transvaginal mesh statement that was published earlier this year. In cases where a patient does not wish to have a midurethral sling, the patient should be offered alternative non-mesh based procedures. And this was really added in recognition that public perception of transvaginal mesh has really changed over the last 5 years. Many women come in with a preconception that they're not going to get transvaginal mesh for a reason. And I think in those cases, it's fine to educate the patient, but in most cases, probably the safer thing to do is to go along with their wishes and offer them a non-mesh based procedure rather than saying, well, there's no other options to treat stress incontinence. The relevant changes that have happened just recently, in April of this year, the FDA ordered all manufacturers of surgical mesh systems for transvaginal repair of anterior prolapse to stop selling and distributing these products immediately. And of course, as with our frustration with the media and many of these releases, a lot of the headlines stated, FDA bans transvaginal mesh. Correct. So what the FDA statement specifically asked was manufacturers stop manufacturing anterior compartment prolapse kits. It doesn't apply to sacral-plexi mesh and doesn't apply to midurethral slings. In July, Health Canada followed suit and updated their warning and stated that synthetic transvaginal mesh should not be used for posterior prolapse repair and should only be used for other types of transvaginal prolapse repairs in very select patient groups. And at this time, the Health Canada statement was just updated a few months ago. No products remain on the market in Canada, so the use of transvaginal mesh kits for prolapse is essentially a moot point. There's no kits available as of now. Again, Health Canada did not address midurethral slings. It said that it was studying the issue and would likely release more information about this in the future, but we wouldn't expect anything to be forthcoming in the near future. We'll move on a little bit to the process of consent. And consent is obviously a process that involves a conversation. It's not signing of a piece of paper. And it's not sufficient to simply say in your note consent was obtained. Consent's a process that you have to go through with the patient, and Dr. Carlson will go through some of the additional details on this. But just as a little primer, when you're thinking about consent for a midurethral sling, probably we all think we do a pretty good job of consent. We throw a lot of information at the patient in a short amount of time. It's really deceiving as to how much of that information actually sinks in with the patient. So looking specifically at midurethral sling consents, this was a good study done a few years ago. Only 2/3 of patients recall the risk of mesh erosion. 16% forgot that their surgery involved transvaginal mesh. A few months ago, I had a woman come in for midurethral sling. On the way in, she said, well, at least I'm not getting that transvaginal mesh stuff, right? And as soon as you hear that, that really derails your confidence in the operation and in your confidence in managing this patient. The first thing you're thinking about is if she gets a complication, this is going to be a disaster because she doesn't even know what I'm doing to her. And the important thing here is that the women who actually forget the complications are also the ones that have greater decisional regret. They're the ones that are more upset about bad outcomes as opposed to the people that remember the complications. So it's really that process of pre-warning the patients and getting their acknowledgement that something could happen with surgery, and here's what we can do to manage it. Preconceptions are important. So again, this was a US study, so a little bit different population than we would see in Canada, but the majority of patients base their knowledge of transvaginal mesh on television, which were predominantly calls for class action lawsuits and people to join them. We're aware of the class action lawsuits. Half thought it could cause pain, a third thought their body could reject it, and 28% thought that it had to be removed from women due to a recall. So this just shows the level of misinformation that's out there in the general public and some of the challenges that you have to face when you're doing informed consent with a patient for a midurethral sling. So I'll stop here on this slide and I'll turn it over to Dr. Carlson.
So I want to talk about consent, understanding that I'm not a lawyer, but I'm going to do my best to review a lot of the guidance that's provided by the CMPA I've put the link to the CMPA's document around consent at the bottom here. This is generic consent advice for all surgical procedures. We're going to speak a bit in specific about consenting patients for mesh implantation, but we're going to talk first about just some generic concepts. So the first thing is requirements for valid consent. Number one is that it has to be voluntary. The patient can't be coerced into consent, of course, and I think we're all aware of this. Certainly hope so. Patients should have adequate capacity to understand the information that's being presented. This can be a challenge at times. And patients need to be properly informed. And this is a real challenge, as that previous slide really highlighted. We need to disclose information to patients and achieve a basic standard of disclosure. And we also need to do our best to try and ensure that patients comprehend the material, which can be challenging. In terms of disclosing information, the CMPA states that the patient must have been given an adequate explanation about the nature of the proposed investigation or treatment and its anticipated outcome, as well as the significant risks involved and alternatives available. This information must be such as will allow the patient to reach an informed decision, of course. The obligation to obtain informed consent must always rest with the physician who's to carry out the treatment or investigative procedure. It may be delegated in appropriate circumstances, but when it comes to mesh implantation, we would strongly support that the physician implanting the mesh, i.e. you, be the one really involved in the consent process with the patient. As Blayne mentioned already, some basic tenets of disclosing information are that we discuss the alternatives to surgery and the various surgical options. In this case, both mesh and non-mesh surgeries, and compare and contrast them. We need to talk about expected outcomes with patients, and this involves both the early and long-term satisfaction rates, and that's where coming to terms with some of the literature out there can be challenging, and reconciling the literature with your own experience as well. I think one point I emphasize is to beware of this discussion of cure rates with patients. I think sometimes trying to talk about curing incontinence can be misleading and a bit of a challenge for us, because we don't always necessarily want to completely cure incontinence. We want to improve quality of life and have satisfied patients. And trying to go for a cure could lead you to overtension a sling or tape, for example. So the discussion of outcomes needs to discuss not only objective success rates, but also improvements in quality of life and satisfaction. Next, we need to make sure patients understand the usual postoperative course and restrictions. It's amazing to me when patients think they can go back to work right away if they're doing physical work. Patients that want to resume intimacy right away after surgery, etc. And these need to be really fully discussed with the patient, and ideally written down and discussed again after surgery. We need to discuss the risks. So in terms of discussing risks of surgery, we have to disclose the material risks. And the materiality of a risk is influenced not only by the frequency of the possible risk, but also the seriousness should it occur. So for example, with mesh implantation, bowel injuries and some of the very serious complications may not be frequent, but given how serious they are, they need to be disclosed. Blayne went into this already, talking about procedure-specific and mesh-specific risks. I didn't break them down quite to that detail here, but we also can't forget to include the generic risks of most operations, which include bleeding, infection, injury to surrounding organs or structures, thromboembolic complications, positioning complications, and anesthesia risks. The procedure-specific risks, Blayne into a bit, but one to include would be failure rates and the fact that there's no guarantee that the operation is going to work or that it's going to last a lifetime. We need to make sure patients understand that they could develop de novo voiding dysfunction or OAB. If they have existing OAB, the operation is not necessarily meant to cure that problem. I find myself spending a lot of time trying to educate patients with mixed incontinence, the difference between the two and what to expect after incontinence surgery. We need to talk about transient or permanent voiding dysfunction, chronic pain and dyspareunia, mesh erosion, mesh extrusion, and fistula. I didn't mention here, but fistula is another specific risk to these procedures to disclose because it could require surgery to fix. Also, when you're discussing advisory mention, we need patients to understand that there are times when complications could require further intervention to resolve them, and that certain mesh complications can have very significant and permanent impact on function and overall quality of life. Mesh is intended to be permanent. Patients believe that the mesh gets, but it's intended to be permanent, and it can be removed, but complete removal is not always possible, and the surgery to remove mesh and additional and significant morbidity. And finally, as previously mentioned, we should discuss the advisories and the current position statement. I'll try, as we get into the Q&A later, I'll try and put up links to these in the discussion section. So here, the Health Canada advisory listed here, I'll post. This was the advisory to hospitals. Post the patient information as well. To COA position statements from 2017 and 2019 that Blayne referenced earlier. Now, having said all that, how do we get patients to actually comprehend what we're talking about? You know, voiding dysfunction, incontinence, lower urinary tract function, very difficult concepts for patients to understand. The CMPA admits that it's unreasonable to expect that a physician has a duty to ensure that a patient has understood the information, but there is a duty, however, to take reasonable steps to ensure that the patient has understood it. Importantly, as mentioned earlier, to be personal attendance by us with the patient. This should allow us to monitor the patient's reaction to the information, and we must allow the patient to ask questions without limits. We can use supplemental and handout material, and we certainly do in our practice exhaustively. But the CMPA has a number of cautions around using handouts and supplemental material, and hopefully we'll get into this a bit with our Q&A later. The CMPA would counsel us to ensure that there's always an opportunity given for questioning and for further discussion after the resource has been viewed. So ideally, you would provide a handout and have an opportunity to follow up with an appointment or a call after the patient has a chance to read it, or have them read it separately and come back to complete their visit. The material should be seen only as an adjunct and not a substitute to consent discussions, and it should not be an integral part of the consent form. The material should be provided well in advance of signing the consent, and very importantly, a contemporaneous notation should be made in the patient record. Finally, the CMPA also says that we should keep all older versions of handout material that's given out, or resource material, and to make notes in your records when updates are made to material. What are the best materials out there to give? You know, most people have their own materials. and we certainly do. If you're looking for society materials, the CUA, SUFU, and IUGA all have accessible patient information on their websites. This as well as to whether there's any needs here for development of any further material or not. What about documenting the consent process? Well, the hospitals, of course, and many jurisdictions require us to have a legal document on a chart, but that is not necessarily the consent. The consent, part of the consent is the explanation given by the physician and the dialogue between the physician and the patient about the treatment and all the important elements. Sorry, that is the all-important element of the consent process. So the consent form is a legal requirement, but it is not the be-all, end-all of the. Finally, the CMPA is very strongly supportive of having contemporaneous notes in our medical records. And certainly a shout out to my office partner who does this better than anyone I could imagine. But anytime we're in a consent discussion with a patient, ideally we should be scribbling down contemporaneous notes in the chart or making notes in the electronic chart. When an informed consent is called into question, a physician's note on the record may be of equal or even greater usefulness for the defense purposes. Courts rely heavily on the progress notes if it's clear that they were made contemporaneously with the events they record. Such notations, particularly if they identify questions or special concerns expressed by the patient, can serve to validate the consent process better than any other documentation. So I'm going to just close with a couple slides kind of summarizing some key points to optimizing perioperative care for these patients and postoperative outcomes. The first, of course, is patient selection. There are many opportunities and options to treat patients with stress incontinence, and selecting patients for a midurethral sling is key to having a successful outcome. Sometimes it's just not the right operation for some patients with incontinence to begin with. Secondly, our workup should be tailored to the complexity of each individual patient. We should educate our patients not only around the possible side effects, how things work, and so forth, but we should also engage them as partners in the postoperative process, telling them what red flags to watch for after surgery that would prompt a call back to our office or a referral back for a follow-up visit if it's been a long time. So a new onset of hematuria, new onset of urinary tract infections out of the blue, voiding dysfunction, persistent self-catheterization after surgery, those sorts of things. Patients need to understand that those aren't normal and those are times when they should be reaching out to us for support and further investigation. Next, we need to be careful about setting expectations with patients. I mentioned earlier the difference between cure versus satisfied. I've also always struggled with definitions of cure in the literature. They're all over the place. And when we get too stringent with definitions of cure, I think we have to be careful because for the most part, I don't necessarily want a patient to never leak again. If they're vomiting or have a horrible cold, I'm okay with them having a little bit of leakage. Just tells me their sling wasn't in too tight. And I think that over-tensioning slings for the most part is where most of the troublesome complications come from. That's my bias. We can discuss it. I mentioned earlier patients with pre-existing dysfunction like overactive bladder, voiding dysfunction, urinary tract infections, etc. We may need to spend, just commit to spending extra time with them, counseling them about the expectations of surgery. The surgery is meant to resolve their stress incontinence in day-to-day life and improve their overall quality of life. What it's going to do to their existing overactive bladder, urinary tract infections is more difficult to predict. Also, the patient voiding dysfunction, abdominal voiding, etc., we might need to be a little more careful in our selection process and our counseling process about what to expect post-op. Number 4, plan for early post-operative voiding dysfunction. I think the first number of days after surgery are critical to ultimately achieving a good long-term outcome for patients. So have a place to deal with post-op voiding dysfunction early on, self-catheter teaching or use of in-office resources like nursing or home care, etc. Having a trigger point as to when to have patients back if they're still having voiding dysfunction post-op. And along those lines, having a supportive follow-up infrastructure in place can be critical as well. Bolsters communications between you and the patient, but also helps troubleshoot and avoid missed complications that become more serious later on. Our office employs early nursing follow-up by telephone. Many people have patients back early on in office. Certainly a routine office visit plus or minus later on is important. Of course, you should have no barriers about patients back at the sign of any red flags. I would not hesitate to book a patient if they called my office after sling surgery with something that might relate to their surgery, rather than forcing them to necessarily go to a family doctor, for example, to book an appointment that might take 6 to 12 months to get in for. So with that, I'm going to wrap up this section on consent and open things up for question and answer. I think we've got lots of time. We may be able to wrap up early, but this WebEx was really in response to feedback from members of the CUA that obviously had concerns about this subject. So we'd like to hear and understand what concerns are. And as a group of all of us online right now, we can certainly share thoughts and guidance if possible.
That's great. Thanks, Kevin. The first question here, I don't know if you can see it or not, but for the sake of everyone else listening, please clarify the role of cystoscopy in the workup for stress incontinence, specifically in patients who choose to undergo a mid-urethral sling. So Kevin, what's your approach to deciding who needs cystoscopy before a mid-urethral sling?
Well, the studies and the data and guidelines would suggest that for the index patient, cystoscopy is not necessary. This is the use of cystoscopy is a bit nuanced. There are places where cystoscopy is the best place to do a proper exam. And I think that's reasonable. It's important to examine patients with a full bladder, and it is frustrating if they show up to the office with an empty bladder and you're trying to prove whether or not they have stress incontinence. Sometimes a cysto, just for practical purposes, may be necessary. But for the index patient with no prior surgical history, no radiotherapy, no significant other voiding dysfunction, normal urinalysis, proven stress incontinence, it's not absolutely necessary to do a cystoscopy.
Yeah, so I would agree with you, Kevin. I mean, I sometimes use cystoscopy exactly for what you said there. You know, there are sort of practical considerations there for the out-of-town patient that shows up with an empty bladder, or you know, for whatever reason has some overactive bladder symptoms and just can't get a full enough bladder to get a good stress test. In those situations, I think cystoscopy is reasonable. I agree. I think everyone's well aware of the red flag stuff, you know, severe urgency, microhematuria, previous stress incontinence surgery, where you'd want to go in and have a look at the bladder and make sure there's no complications or abnormalities before thinking about surgery. But otherwise, you're going to be performing a cystoscopy at the time of the mid-urethral sling probably, so you would also identify any incidental findings at that time, hopefully. I don't think it has a role in every woman, and is something that's at most optional in the evaluation of these patients. Moving on to the next question. How do you decide, or what do you use to make a decision as to whether you do a TVT or a TOT, specifically in reference to previous abdominal surgery? So just to start, I would say the TOT has a specific role in a few types of patients where I think it does provide a much safer alternative. So someone with significant bowel surgery and lower abdominal surgeries, you may want to consider a TOT preferentially in that patient. Try to avoid the risk of bowel injury. Sometimes you can look on imaging and see they've got a smaller bladder capacity. You can see the bowel sort of stuck down on top of the bladder. That patient, you may want to consider a TOT. Similarly, in my practice, I've used it for people with renal transplant and people with neobladders and stress incontinence. Those are two situations where you really want to avoid the risks of a retropubic approach. Kevin, do you have any other comments on that, or maybe your approach to a patient with an abdominal hernia with mesh repair? Would that dissuade you from doing a retropubic approach?
Yeah, I would say that I'm generally a big fan of the retropubic approach over transobturator. My bias is that outcomes are a bit retropubic versus transobturator slings, and I don't like the groin pain and higher extrusion rate in the vaginal fornices that you see with transobturator tape. So my bias is certainly towards retropubic slings. I'm pretty comfortable passing those slings in most patients, but probably the few that you've just mentioned that I would shy away from are the transplant, the neobladder patient, and if I can palpate mesh along the tract of where I would plan to pass my device. So those are pretty rare in my practice. So, you know, most of the time for patients with a prior bowel resection, etc., I'm okay having at a retropubic sling pending the physical exam, of course.
All right, excellent. And then the next question was recurrence or failure rates of the midurethral sling compared to traditional procedures. So I mean, there's been a lot of meta-analyses looking at that. I think the midurethral sling probably does a bit better than retropubic suspensions. The last ones I've seen generally have suggested that the cure rate or the success rate is fairly similar with pubovaginal slings or fascial slings at the bladder neck. I don't personally think there's a big difference between those surgeries. Retropubic suspensions, again, the systematic reviews would seem to suggest it's a little bit better, but again, the difference is not that profound. I don't know what your perception is, Kevin.
Yeah, I think nothing's been studied as well as the midurethral sling, so comparing data is a bit unfair because there's simply not as much of it when it comes to non-midurethral sling surgery, and you know, all suffer from the same problems of differing definitions of cure and failure. You know, the best study out there that compared them, I think, used too stringent of a definition of success or cure. So it's a bit tough. I certainly don't tell people that these operations are proven to have a greater success long term than, for example, a bladder neck fascial sling. But I'm not 100% that I know that for sure.
All right. And then here's one that circles back to what we were discussing a bit before. Does leaving a sling too loose predispose to mesh exposure?
I don't believe so. To mesh exposure, no. Certainly leaving one too tight predisposes to mesh erosion.
Yeah, so
I'm happy to
I
say that.
agree 100% with you on your bias. I think too tight's the error, not too loose. Something after you've taken out a bunch of slings or done a bunch of erythrolyses, you see that the sling when you do that is always like really thin, right? It's like 2-3 millimeters in diameter, and I think that's just the sling either tightening with time or being put in tight at the onset. I think really not trying to tension your sling to the patient is key. I place all of mine exactly the same way, no matter whether they're wearing diapers or a few pads a day. You shouldn't be tensioning more in the average stress incontinence patient because you think they need a tighter sling.
Yeah, the only thing that having it too loose might do if you're not careful is you might pick it up in your closure. So that just just requires meticulous closure, pulling the edges of the vaginal mucosa over the sling before you close it, and then just being uber careful about not picking up the mesh as you close. Otherwise, I don't risk of mesh extrusion. I think that mesh erosion is happens for a few different reasons. One is too much tension on the sling, which is probably the most important thing. The other is dissecting deep through the periurethral fascia, and then the third would be a trocar injury or a surgical injury in the process of dissecting. The some residual incontinence is not a bad complication, but I'm the same as you. I tension it the same all the time. I tell people that if they get a horrible cold and they have some leakage and have to wear a pad for a week, I'm certainly okay with that. Tells me that I did, so those are my biases. The other thing I would say about success rates is there's also positioning of the sling along the urethra might make a difference. It's meant to be mid urethra. I think slings that are too proximal are also a problem, and I see that more with referrals for T's for whatever reason. Maybe the dissection's bigger to get your finger in there to facilitate trocar passage, but it's been an observation over the years.
Right. Next question. So this is about one of the slides I showed. There were differences between the numbers of lawsuits between the different companies on your slide. Does this reflect differences in quality? So I would say no, probably not. I'm not sure that any of the companies really intrinsically made a different product other than different approaches, whether it go transobturator, retropubic top down, or down up. So I don't think it reflects any differences in quality. I think it just reflects differences in market share. As far as I know, no one's really been able to show there's any significant differences in complications, like mesh-specific complications between TOT and TVT. There's a bit higher rate, as Kevin said, of groin pain with TOT, and mesh exposure in the vagina is fairly similar between the two, slightly higher with TOT, and risk of serious complications such as bowel injury or vascular injury is a bit higher with TVT. Overall, I don't think you can use the lawsuits as a barometer to measure quality of the different types of slings. Else there, Kevin? Or
yeah, I would agree with you. I don't think it says anything about the quality. It could be volume based. It could be just be the particular just details of particular class action suits, but I don't think it's necessarily the product because they're all using type mesh, and yeah, so I would agree with what you said.
Excellent. So the next two questions here deal with how to treat or manage a patient with a mesh erosion into the urethral bladder or mesh extrusion into the vagina. That's a big topic. We could probably talk for 15 minutes on that, but maybe as a brief overview, how would you generally approach the patient with a vaginal exposure, Kevin?
So the vaginal exposure is going to be minor exposures. Minor exposures initially could be treated topically, estrogen replacement like Premarin cream, depending on the age and the estrogenization status of the patient and the degree of exposure and symptoms. Otherwise, otherwise beyond that, things depend on how big of an exposure it is and whether it's complicated or not. Most of them are not complicated. They're clean. They're not associated with a fistula, etc. But I would cystoscope those patients to make sure there's no fistulization or urinary tract involvement. And in brief terms, I'd say your options are either to mobilize the vaginal mucosa in 360 degrees around the mesh and freshen the edges and close it primarily, or to undermine it and excise a small portion of mesh, understanding that for recurrent incontinence. It's a very brief overview of something we could go on longer about.
Yeah, no, I mean, for sure, there's a lot of factors in terms of whether they have recurrent incontinence, whether they have you have to take all those things into consideration. So I don't think there's an easy answer, but ultimately, just because you find a vaginal exposure, I don't think you're obligated to do anything about it. You can observe it, especially in a woman that's not sexually active. You can observe it with serial exams once a year for a while and tell her, look, at some point this may need to be addressed, but for now, let's watch. Urethral exposures are a little bit different. Generally, I've tended to treat those. The treatment options for those, usually they're discovered either incidentally as someone worked up for recurrent incontinence, say, or for someone that presents with obstruction or frequent urinary tract infections, and you find mesh and some stone material within the urethra. So two approaches to manage those. One would be endoscopic, and two would be open surgery. For me, I've had pretty good success with endoscopic management. Not everyone has, and some people prefer to go straight to open surgery. Again, it's a complex decision. If they have recurrent incontinence already, then maybe you have a little bit less to lose by doing an open revision. If they have pain, then I would say the endoscopic revision is a little bit less likely to be effective. I usually like to start with anything I do minimally invasive, so I'll usually try the endoscopic excision first with a laser, and then move on to open revision if necessary, knowing that open revision is going to need a larger piece of the mesh excised and the potential risk of fistula formation afterwards.
Yes, so I would agree with you 100%. I will try to manage those endoscopically up front. For the urethral erosions, what I tell patients, unless they're in horrible pain or something where you're gonna want to go in and try and get a resolution in a more aggressive manner. But for the vast majority of patients, what I tell them is I'm going to start with an endoscopic approach, try and get the mesh out of the urethra, and then usually what happens is that it will retract the urethral, the edges will retract out of the urethral lumen over a number of weeks. I'll have them back and look again, and if there's still exposed mesh or if they're still symptomatic, then I'll offer them an open excision of it. And what I've found is if you go in open after you've endoscopically removed the intraluminal component, that you can quite simply tease out each end of the mesh from the urethra and close it quite simply with less morbidity that way. Whereas if you go in on a urethral erosion in an open front, basically need to splay open the urethra, do a much more aggressive dissection to get the mesh out, and then the the closure is a little bit more challenging, and certainly the risk of complications probably goes up a little bit. And then personally, I don't use a laser. I use usually a pediatric cystoscope or something, and advance an instrument, advanced scissors alongside it, or get a clamp on it and cut by feel. I just struggle with the laser, especially if it's in the distal urethra and I can't get flow. But that's just whatever you're comfortable with. For the bladder erosions, I definitely would do a laser excision up front. And sometimes I'll put a 5mm trocar suprapubically into the bladder to grasp the mesh and get it on tension, so that I can get a deep section and clean resection on each end of the mesh. So we've had good success.
Excellent. What's your opinion on single incision slings?
I've done one and don't plan to. My opinion is that it's really, I can't say much because I haven't done it. I only know there isn't a good volume of literature out there. It's not. I'm happy with the product. I've always been happy with the product that I've been using, so I didn't feel the need to switch. So that's me.
Yeah.
Tough to answer that question. I've done one.
Yeah, I've never done any either, quite honestly. The TVT Secure gave everything a bit of a bad name years ago, and other products that come on the market, they may be okay, but the issue is I'm not convinced that any of them will necessarily have a lower risk of erosion, lower risk of pain, or lower risk of vaginal exposure. So I'm not sure I'm necessarily getting a lower complication rate, and I'm skeptical if efficacy is equivalent, especially just knowing what I know about stressing complications over time, and the possibility that the slings loosen with time, and the stress that sometimes women put on it with their physical activities. I think they need a fair bit of strength in them, and I'm not sure that the mini slings are able to do that yet. So in the mesh statement, it says there, further study is needed. That's what we said back in 2015, and or 2016, and I don't think I would change that point yet. I think there's more study needed, and I don't think there's anything out there that's a clear replacement for the mid-urethral sling yet.
Sir, do you know if the products are available on market still in Canada, or does whoever wrote that question, do you still have access to them? Because we don't in our region right now. I don't believe.
Yeah, I know there's people marketing them in Ontario right now. I'm not sure if there's other ones out there.
Yeah.
Manage mixed incontinence with detrusor overactivity directly following stress incontinence. That's a bit of a tricky one. That's another huge topic. New onset of urgency incontinence post sling. Kevin, what's your brief algorithm for that?
That's the classic patient that comes in and says, the operation didn't work. And then you really have to, get into the discussion of, well, did it or did it not? Are you leaking if you cough in the lab? And usually the answer is no, and they're leaking with urgency. So first thing I do is, well, right out of the gate, I'm going to do a Euroflow study in my office to make sure they're not in retention, or they have significant voiding dysfunction. If they did, that's a problem. And I'm going to ask them first of all if they had to self-catheterize for any perioperative surgery, because that would also tweak me to think more about obstruction. The other thing I'm going to do is go back and look the initial history and just see if this is pre-existing OAB that's maybe a little worse right now. So rule out obstruction, and if there's any sign of obstruction, depending on the time frame, I might do urodynamics or, even a release. But if they just have isolated overactive bladder, either de novo or it's just a flare up of what they had before, and they're voiding with a good flow and emptying completely. Sorry, my light keeps going out. Then I'll give it a number of months on an OAB oral agent and reassess them.
Yeah, no, I think it's fairly similar. I mean, the key is it new onset or not? And if you're seeing the patient back for follow-up and you're confident this is something that's new that's happening, then you got to wonder, did your sling do it or not, or did it just unmask existing mixed incontinence? And I think if you can conclusively, prove or convince yourself or have the patient convince you this is something new, that wasn't there before, and it's a significant problem for them, you could consider a sling incision. I wouldn't do it early. I'd wait at least 6 to 12 months or 6 to 12 weeks to let the sling heal and provide some long-lasting benefit for the stress incontinence. And then the question would be, do you want to do a sling incision or not? And that's a discussion you'd have to have with the patient, depending on how bothered they are by it. So when you look at the studies of mixed incontinence, the urgency component usually is the bothersome component. That's usually what people want fixed. And if that's a new onset thing, that could be bothersome and could be something you should try to address fairly aggressively. We've got 2 minutes left here, so we'll just go through a quick question. Failure of topical treatment with a small vaginal exposure, would you just observe it 100%? I think Kevin and I discussed that before. In a lot of cases, you can just watch that patient and make sure they're aware of what's going on, make sure they're aware they could need surgery or treatment for this in the future, but right now it's something you can just watch. Finally, last question, urinary retention post-sling. When will you loosen the sling, or how long will you wait? In the first couple of days after surgery, you probably could loosen the sling. I think as you get close to a week after the sling's gone in, it's pretty unlikely you're going to be able to loosen. In that case, if someone's in retention, if you caught it within the first couple of days, I think I would probably be pretty aggressive about going back in and trying to loosen the sling. Just open up the incision, grab the edges of the mesh and try to pull and try to loosen it a little bit. Use a sound and push down, because I'd worry that's just crushing the mucosa against the sling and just going to lead to an erosion. If it's after a week, then I'd say, okay, we got to put up with the retention for a couple weeks, let the sides of the sling scar into position, and then at least hopefully the patient will get benefit from a stress incontinence perspective with some lateral support still when you go in and do your sling incision at sort of 4 to 6 weeks after surgery.
I would agree with all that 100%. Certainly, I've never endorsed putting a sound in and pulling it down to try and loosen. If you're going to loosen, you open the incision and you pull it down. It's got to be done within a week. And for me, I would only do it if they were in complete retention. And I haven't done it in years. It's pretty uncommon. They'd have to be in complete retention. And you just got to be careful. Sometimes it's just, it's dysfunctional voiding resulting from the surgery, and sometimes you got to give it time. And I totally agree with just leaving it a little longer, because I think they'll do better with a lysis at that point, or an incision, I should say. So I like that approach a lot. Outside of a week, good luck.
All right. Well, thank you guys very much. It's 10 p.m., so I think we'll wrap it up there. I hope this has been useful for you, and again, SUI know about events and information that you need, and it's important that we support urologists across the country and provide information that's useful to you. So make sure you let the CUA know what your educational needs are, and forward to speaking with you guys again.
I'll just put one plug in at the end here before we go, and that is this year's CUA, we had our inaugural meeting of the Functional Reconstructive Urology Society, which is a new affiliate society of the CUA. If you weren't already at that meeting, there will be another one at the upcoming CUA, and I would stay tuned for notices about that. That can be an avenue for us going forward to do more events like this and for developing materials and that sort of thing in the future.